Hello everyone, welcome to Pharmacology Chapter 39, Lower Respiratory Disorders. We're starting out with COPD, and we've talked about COPD a lot, but just briefly, COPD is an obstructive lung disorder, and this means that air's getting trapped in the lungs because the airway's narrowed, and it's narrowed by inflammation and mucus. So the patient works harder to breathe, and that means CO2 builds up and oxygen levels drop. So COPD is usually caused by chronic bronchitis and emphysema. And our medication focus is bronchodilators and reducing inflammation. So we just talked about what COPD is as far as the patho, and you could see some major causes. But just I want to hone in on some common symptoms that you're going to see is dyspnea or difficulty breathing, that barrel chest, and the use of accessory muscles. So when you're obtaining history on a patient and they present with these kind of symptoms, make sure that you ask if they have had a diagnosis of any type of chronic lung disease. Some advanced COPD causes are the pulmonary hypertension and right-sided heart failure. On this slide, all I'm going to mention is that we have contrast obstruction and versus the restrictive. So obstructive means it's a problem getting the air out, and the restrictive is a problem getting the air in. Restrictive lung disease is like trying to blow up a stiff balloon. The lungs cannot expand, so total lung capacity drops. So causes can be fluid, fibrosis, tumors, or muscle weakness. So instead of wheezing and air trapping like COPD, restrictive patients often have that rapid, shallow breathing and low oxygen. We've talked a lot about asthma, but I'm going to do just a brief overview again. Asthma, inflammatory airway disease that causes reversible bronchostriction. Asthma is actually inflammation plus mucus plus airway narrowing. So common triggers we've talked about: stress, allergens, and pollutants. Severe asthma may result in what's called silent chest, where the wheezing stops, which is a bad sign. Bronchial asthma, just a little bit of a step-by-step breakdown how it happens. Allergens enter the airway. The immune system recognizes that as foreign. Allergen binds to mast cells and basophils. Antigen-antibody reaction triggers the mast cell degranulation. So the mast cells actually release the mediators, and we've talked about these mediators: histamine, leukotrienes, and prostaglandins. Remember the prostaglandins? These cause swelling, bronchoconstriction, and mucus production. So airway narrows, increases resistance, causes the wheezing, and then the dyspnea or difficulty breathing. So a big takeaway from this I want you to know is asthma attacks are immune driven. Asthma is often episodic, but inflammation is present even between attacks. So just for a summary, in asthma, allergens trigger mast cells. Mast cells release inflammatory mediators like histamine and leukotrienes, which cause the swelling, the mucus, and the bronchoconstriction. The airway becomes narrow and resistant to airflow, which creates wheezing and shortness of breath. Okay, this figure shows how asthma spirals. So just take a look at this picture. Inflammation causes swelling and mucus, which narrows the airway and triggers bronchospasm. And as the airway narrows, air trapping increases and the oxygen drops. The patient becomes fatigued, and of course, without treatment, this can progress to respiratory failure. So chronic bronchitis is defined as productive cough for at least 3 months for 2 consecutive years. So some patho on the chronic bronchitis: it's a chronic irritation, especially in smoking. Increased mucus glands, thick mucus blocks the bronchi. And then the cilia, which I'm sure y'all remember, is that hair-like structure that's kind of acts like a broom. The cilia are damaged and cannot clear the secretions. So the result of all this is the mucus plugging, which results in poor airflow, poor ventilation, which results in CO2 retention. So chronic bronchitis are called blue bloaters. I don't know if you've ever heard that term, but chronic bronchitis is blue bloaters. Blue, of course, because of the hypoxia that can happen, and then bloaters because of the fluid retention and swelling. So more cyanosis, edema, and frequent infections. So for a summary, chronic bronchitis is a COPD with mucus as the major problem. Smoking causes airway inflammation and thick secretions, leading to productive cough and airway obstruction. Patients often retain CO2, causing respiratory acidosis, and may appear cyanotic due to the chronic hypoxemia. Bronchiectasis is a structural airway disorder. The key concepts here I want you to know is bronchi become permanently widened. Mucus pools inside and bacteria grows easily because of that. And then chronic infection can develop. So the patho on that is repeated infection damages the airway. The airway loses its tone. It dilates abnormally, and then clearance becomes poor. Mucus builds up and blocks the bronchioles. And then the major risk of this is recurrent pneumonia, chronic productive cough. So bronchiectasis is a permanent dilation of the bronchi due to chronic infection and inflammation. The damaged airway traps mucus, which becomes a breeding ground for bacteria. These patients often have recurrent infections and thick sputum, so airway clearance is a major nursing priority. So let's talk again briefly about emphysema. Just to recap, emphysema is COPD, where the problem is destruction of the alveoli. They call emphysema patients pink puffers, and they call them that because pink, they have better oxygen levels longer than the chronic bronchitis that they call blue bloaters. Puffer because of the pursed lip breathing. They have a thin body type, and sometimes they'll be in a tripod position. That's where the patient leans forward with their hands on their knees, hands on a bed or table with their elbows braced, and it just helps them breathe easier and expand that chest wall. So just an overview again, emphysema is COPD caused by destruction of the alveoli. Smoking triggers inflammation, and enzymes release that break down alveolar wall. The lungs lose elasticity, causing air trapping and poor gas exchange. Patients often use that pursed lip breathing to help push the air out. Again, smoking, number one cause. And then I want to mention this alpha-1 and antitrypsin deficiency. It is a genetic disorder, and it normally protects the lungs from the enzyme destruction. So without it, the lung tissue breaks down earlier. Emphysema can develop in younger adults even without smoking because of this. So be aware of that. Recap, emphysema is most commonly caused by smoking, but a genetic cause exists called the alpha-1 antitrypsin deficiency. These patients lose protective proteins in the lung, so alveoli are destroyed faster. Always suspect this in a young emphysema patient. Okay, let's talk about some important information about epinephrine. Epinephrine stimulates alpha receptors, causing vasoconstriction. Beta-1 receptors increases heart rate. Beta-2 receptors, bronchodilation. The use is usually in an emergency medication, fast-acting rescue drug. It's especially used for anaphylaxis because it opens the airway and supports the blood pressure. Side effects, tremors, tachycardia, hypertension. We need to make sure we're monitoring the heart rate. Epinephrine is a powerful rescue bronchodilator, but it also stimulates the heart, so watch for tachycardia, hypertension, and dysrhythmias. About albuterol, but we're going to briefly touch it again. It's a short-acting beta-2 antagonist. The main purpose for albuterol is quick relief during acute bronchospasms. It has fewer side effects because it's selective for beta-2 for the lungs. Important teaching is it's a rescue inhaler. Tremors, tachycardia, palpitations, and nervous excitability are some of the side effects that we need to know. So just to recap, albuterol is the classic rescue inhaler. It rapidly relaxes airway smooth muscle through beta-2 stimulation. If a patient needs it frequently, then that is a red flag that asthma is poorly controlled and inflammation management must be improved. Continuing some bronchodilators, triotropium, known as Spiriva, is for COPD maintenance. It's a dry powder, and some side effects that's important to know is dry mouth, constipation, insomnia, and infections for this medication. The key use again, COPD maintenance, not for acute asthma attack. It's inhaled only. Make sure they rinse their mouth after use. An overview is a COPD maintenance medication. It works by blocking acetylcholine, which normally tightens the airway. So by blocking that signal, the bronchi stay open. And it's not a rescue inhaler, and common side effects include dry mouth and constipation. Just to continue on this one, oxygenation is the priority. Wheezing and cough suggest bronchospasm and mucus. If the patient's dehydrated, secretions thicken and worsen obstruction. So our goal is to improve breath sounds and reduce dyspnea within days. Bronchodilator continued, just some quick things. You can read the slide, but monitor the vital signs, ensure hydration, because that's going to improve cough clearance. The medic alert badge or tag or something like that's good for first responders or emergency responders when they have to act quickly. So just to recap, bronchodilators improve airflow, but they also affect the heart. So that's why nurses monitor vital signs and watch for tachycardia. Hydration helps loosen secretions, and consistent dosing helps prevent bronchospasm episodes. Moving to a leukotriene receptor, montelukast, known as Singulair. The action is to reduce the inflammation and bronchostriction. It's used in asthma and exercise-induced prophylaxis, not for acute attacks. Some side effects include dizziness, depression, and infection. So leukotrienes, going back to recap, are those inflammatory mediators we talked about that's released during asthma reactions. So what the leukotrienes actually do is they tighten the airway smooth muscle, and then that montelukast blocks the leukotrienes, so it prevents the airway narrowing, reduces chronic inflammation. So montelukast is not for acute asthma attacks, and it's taken daily for control. Some side effects that are common, though, are headache, dizziness, GI upset, and mood changes. Sometimes they'll see depression with this medication. It's a controller medication. It blocks the leukotrienes, which are inflammatory chemicals that tighten the airway. It's used for prevention, especially exercise-induced asthma, but it does not work fast enough for acute attacks, and monitor for mood changes. Asthma symptoms like wheezing and dyspnea suggest airway obstruction. Montelukast reduces inflammation gradually, so improvement is expected over days. Take time to read your slide, but just some things I wanted to mention in addition is with these leukotriene receptor antagonists is monitor the liver function. And liver function is monitored because some asthma drugs can stress liver metabolism. Just to recap again, leukotriene blockers, we're focusing on the respiratory assessment and safety monitoring. So we want to watch for wheezing, cyanosis, and changes in breathing. Encourage smoking cessation because smoking worsens inflammation and decreases asthma control. Our glucocorticoids we've talked about, but we're going to talk about the fluticasone called Flovent. You'll just hear me say Flovent. The action of Flovent is it's an anti-inflammatory. It's used as an inhaler, oral or IV. Side effects are oral irritation, hyperglycemia, of course, osteoporosis, and superinfection, all those things we know about steroids. Steroids are a cornerstone asthma therapy because asthma is an inflammatory disease. So Flovent is an inhaled corticosteroid. It's not rescue meds. They prevent attacks long term. Some common side effects are hoarseness, sore throat, and oral thrush or the candida. So make sure you're teaching them to rinse their mouth. Steroids suppress the immune system. which increases the infection risk. So just to recap, steroids treat asthma at the root cause, inflammation. Inhaled steroids like fluticasone or Flovent reduce swelling and mucus to prevent attacks. The most important teaching is to rinse the mouth after each use to prevent thrush. And remember, inhaled steroids are controllers and not rescue inhalers. Cromolyn nebulizer, its action is inhibits histamine release, preventing attacks, used in asthma. Side effects are cough and postnasal drip, and some adverse effect would be rebound bronchospasm. Its mechanism of action is it prevents mast cells from releasing the histamine, and it stops allergic cascade before it begins. It's used for prevention only, and it must be taken before exposure or triggers. It's not effective for acute attack. Other side effects, cough, throat irritation. Good option for mild asthma prevention, especially in children. Cromolyn prevents asthma attacks by stopping mast cells from releasing histamine. It's used before exposures to triggers, not during an acute attack. Watch for cough and throat irritation and report any worsening bronchospasms. So now we're going to talk about drug therapy for asthma according to the severity, and this is a priority NCLEX concept that you may see. Number one, long-term control of asthma include inhaled corticosteroids, leukotriene modifiers, long-acting beta agonist, and mast cell stabilizers. For quick relief or rescue, it's our albuterol and epinephrine that we talked about. If a patient relies on rescue inhaler frequently, their asthma is uncontrolled, and we have mentioned that before. If albuterol is used daily, what medication needs to be added? Think about that. The answer is inhaled steroid controller. So just for a recap, think of asthma meds in two groups, controllers and rescuers. Controllers reduce inflammation and prevent attacks, and rescue inhalers open the airway quickly during an acute bronchospasm. And if a patient uses rescue meds too often, then the asthma plan is failing. Very briefly, in pediatrics, we use safer preventive meds like cromolyn, while older adults require caution because bronchodilators stress the heart and steroids worsen osteoporosis and glucose control. Our last medications that we're going to talk about is antimicrobials, and specifically Bactrim. The use is mild to moderate exacerbations of chronic bronchitis due to infection. Bactrim is used when chronic bronchitis worsens, sputum increases, sputum becomes purulent, and fever develops. A simple mechanism of action is it blocks folic acid synthesis in bacteria, and then bacteria cannot replicate. Some important nursing considerations is encourage fluids to protect the kidneys. Make sure you do a good assessment for allergies, especially sulfa. Monitor for rash and photosensitivity. So just to recap, Bactrim is an antibiotic often used for infectious COPD flare-ups. COPD patients trap mucus, which becomes a breeding ground for bacteria. Always assess for sulfa allergies and monitor for rash because severe skin reactions can occur.